Good evening, everybody, and welcome to this event hosted by the Foundation for Science and Technology on this important subject. Welcome to the Royal Society, those of you here in person, and welcome to everyone who's joining us remotely on YouTube. Health policy implications of climate change are the subject, very, very important, very relevant, and it appears that climate change is already happening here in London. The regulars amongst you might have expected Lord Willets to be chairing here, but unfortunately he can't do that, so I'm afraid you've got me. My name's Sandy Trees. I'm a crossbench peer in the House of Lords, and it's a pleasure to be chairing this important subject. Before we get to our speakers, there are a few technical things just to explain. We will be letting online participants submit questions through Slido. To ask a question, you can use your mobile phone or log on, as the slide indicates, to www.sli.do and enter the code hashtag 1789886. In the audience, you can ask questions directly, or you can submit them if you so wish through your smartphone. And please, when people are asking questions either online or in person, do give your name and affiliation so that we all know who you are. And finally, if you want to tweet about the event, you're welcome to tweet with a hashtag FST Climate Health. So, with regard to the topic, we are seeing the effects of climate change, of course, and environmental models give us a good indication of what we can expect in the next 10, 20 or 30 years. The changes in climate are already affecting human health. There may be good effects in some places, and there may be bad effects in other places. But we can predict with a degree of accuracy some of those effects. And they will become more acute as the global temperatures rise. So in this event, we want to discuss some of these issues. What sort of health changes can we expect with the sort of climate changes we are anticipating? And how can we build a wider health policy to tackle some of those issues? So I'll introduce the speakers now, but first a slight apology. I thought we had a very good, diverse list of speakers with 2 ladies and 2 gentlemen, but I'm afraid our 2 lady speakers have yet to appear. They may appear, we hope they will, but if not, that's the reason we only have 2 white male speakers. But we have very distinguished speakers. So without further ado, let me introduce the first speaker, who really needs no introduction, Professor Chris Whitty. Is of course the Chief Medical Officer of England and the UK's Government Chief Medical Advisor and Head of the Public Health profession, and also a practicing NHS physician at UCL here in London. Chris is an epidemiologist by background and was Professor of Public and International Health at the London School of Hygiene and Tropical Medicine for some time before he was made CMO. And Chris has served as the Chief Scientific Advisor previously, both for the Department of Health and Social Care and the former Department for International Development. And he was Interim Government Chief Scientific Advisor from 2017 to 18. So we look forward very much to what he has to say. He does have first-hand experience of delivering healthcare in hot climates as well. So, Chris, the stage is yours.
Thank you. So I recognise many people in the audience who I know either from medicine or from being responsible for the climate change research programme in DFID, late lamented, or elsewhere. So I'm really looking forward to the debate on this, which I think will be very well informed, given the audience. The points I'm going to make are relatively straightforward ones. The first, which we just have to say, because it is obvious to everyone in this audience, but I'm afraid it is not obvious to absolutely everybody who's involved in policy, is the negative effects of climate change are very substantial. Trying to go up a slide. Wait a minute. This is what happens when I'm allowed to do my own slides. Can someone help me just go up a slide, because I've just gone one slide too many. I want to get up. Good, that's the one. Actually, it would be more helpful if I had it. That seems a good idea. Thank you very much. It's widely accepted that the effect on climate change is one of the greatest threats to human health. That, I think everyone who's looked at that long term doesn't dispute that. Obviously, in the short term, there are very, very many very major impacts on health. And in the short to medium term, you could argue that X or Y is more pressing. But if you take a long-term view, then that changes. And the reason for that, and this is widely accepted by WHO and most other major health bodies. So this is, in terms of the established view among scientists who've looked at this is not a particularly controversial statement. The reason that this is really important is that for a great many of the health problems that we face with climate change, we can reverse out of them or counter them in relatively short order. Climate change effects, once they take effect, are not going to be reversed in the foreseeable future. So the area under the curve for these changes is substantial. Even if the effect itself appears modest, a modest effect for an almost infinite period in terms of human existence is actually a potentially very major effect. So the area under the curve is very substantial. The negative effects on climate change on health are obviously not distributed evenly globally. And there are multiple reasons for this, but I'll broadly divide them into reasons of the science of it, the biology, the atmospheric physics and various other areas, and reasons of economic and social development. Just start off with the scientific reasons. I'm just taking two examples, and I could have taken many. If we see, as a result of climate change, as we will, a change and probably an increase in the destructive power of storms, it is fairly predictable, at least in the short to medium term, where they will be. They'll be where storms are already. On the left is a map of all the hurricanes and typhoons between 1816 and 2015. If you're in the Caribbean, if you're on the eastern seaboard of India, if you're in parts of Southeast Asia, the impact of this will be absolutely massive. Much less so if you're in multiple other areas, including large swathes, for example, of Africa and much of Europe. So this is a geographical fact that some areas will be affected more by that particular element of climate change. And there are many others where you can pick them out. And on the right here, I've taken a slightly different one. This is from the IPCC, and this is changes in consecutive dry days. Now, this does not translate straightforwardly to drought, and it does not translate from drought straightforwardly to hunger and then to famine. But nevertheless, there is a broad correlation. And as you can see, again, over depending on what timescale you talk about and what temperature rise we get to, this is distributed differently in different parts of the world. So these are, and I could repeat this over many different factors, there are biological and physical reasons why the geographical distribution is not going to be even everywhere. But this is going to be exacerbated by the fact that there is also much greater vulnerability to the effects of climate change in some environments than others. This is largely driven by socioeconomic factors, but not entirely. And therefore, someone living in the Sahel, for example, will firstly be affected by climate change earlier in terms of the severity of impact than someone living in, let's say, Yorkshire, but also the vulnerability of the system is much greater. So the impact on individual lives and on human health will be greater. And the biggest impacts will be those where the climate change effect, geographically, and the vulnerability coincide. And very many of those, I think, are relatively easy to pick out. But to be clear, the negative effects on health will be everywhere. It's just they will be differential. Now, if you turn to UK and Europe, and I'm going to talk about this largely because that is my current responsibility, all of the things I'm about to talk about are also true globally. but let's just take Europe. There will be direct effects, and direct effects are things like increases in heat stress, and we'll see probably over the next week that can be very difficult, depending on where we get to. We saw this, for example, in Paris a few years ago, really very significant impacts on mortality of people with cardiovascular or other risk factors. There will be impacts on flooding, for example, different forms of flooding, particularly surge flooding. So these direct effects will have exact, line of sight impact from climate change through to negative health impacts. But then there are multiple indirect effects, and I've just taken a few of these. Vector-borne, diseases, for example, will change their range. On balance, they will certainly increase the range of many vector-borne diseases, and they will certainly move them around to places where currently, for example, there is limited immunity. And these include mosquito-borne diseases, tick-borne diseases, which include many of the great killers, malaria, for example, a disease I worked on for many years, and many of the viral vector-borne diseases. Then there are a large number of negative consequences of the indirect effects on water systems, ranging from people having too little water to wash their hands, leads to diarrheal diseases, through to impacts on the economy and on different sectors of the agricultural system. There will be indirect effects on the agriculture more widely, including animal and plant health, and these will in some areas lead to food insecurity. Again, that's less likely to be true in a wealthy country like the UK, but it will certainly be an issue in very many other areas. Again, we're seeing that the food economy system in the world is surprisingly fragile. I think most people would not, for example, have realised that a war in Europe would have a knock-on effect to food security elsewhere. This is on quite narrow boundaries. Quite small changes can lead to quite big consequentials in this area. There will, of course, be major global impacts on socioeconomic development, and everybody, I think, would accept that the biggest predictor at both a micro household level and at a macro country level on human health is human socioeconomic development and wealth. So this is going to have very long-term impacts, which will be multi-generational. And of all of these will be an even greater risk in Africa and Asia. And I've just taken for the UK, but this would be much more extreme if we were talking about, let's say, northern Nigeria. This just happened to come out last week. I thought it's a nice paper looking at heat-related excess mortality now. Where there is excess mortality now will be the places that first see this with climate change, and London actually is one of them. Now, what should be the policy responses? And I was asked largely to give views on this, in or with an impact on health. Well, I think there are broadly four, and I'll re-put this slide up at the end. This is essentially my summary of the key points. We have to get healthcare as an industry, as a profession, as a group of activities, define it as you wish, as close to net zero for carbon and other greenhouse gases as possible. It is a significant contributor, not the biggest, but it is a significant one. And the world is full of people who actually say, we completely agree that carbon should go down, but not in my industry for the following reasons, because we're really important. Healthcare cannot be exempt from this. The second thing is that we must promote policies that have, I'm now going to speed up because I'm glad to see that one of our co-presenters is now arrived. That's excellent news. So therefore, I'm not filling time that she will be doing things. We must promote, and this is the easiest bit, policies that have co-benefits between mitigation, reducing carbon, and health benefits. We must find medical countermeasures for diseases and conditions which will increase with climate change. Climate change is happening already and will continue to happen. However good we are in the next few years at addressing this, we therefore have a responsibility as part of adaptation to address these. And science has a very major role here. And finally, and I cannot stress this too strongly, we must be honest about trade-offs. There is a slight tendency to try and wish away trade-offs because that makes the argument easier. But actually, if you're not honest with yourself and with others about the trade-offs at the beginning, you end up with bad policies, badly designed, and where people feel that they've been sold a dishonest situation because they weren't told about them at the beginning. People need to have both sides of the argument put to them honestly and properly, and science has a major role both in identifying the trade-offs and in minimising them. And I'd like to highlight two excellent reports, this one by the Royal Society and then a joint one by the Academy of Medical Sciences and the Royal Society, which actually explores some of the areas where trade-offs occur. Now, just to give, this is 3 slides just to flesh out the main points that I've made so far. So, healthcare and net zero. Here are some of the multiple ways in which healthcare, and in this case I'm taking the UK, but the same is true in many other countries, probably even greater, for example, in the US, contributes to carbon through construction. Very popular. But the fact is, construction can be more or less carbon intensive, but it is still going to produce a lot of carbon as it happens. Heating and, as we'll see in the next few weeks, cooling. Hospitals and clinics have to be warm or indeed cool enough. They have very vulnerable patients who actually cannot go above or below particular temperatures without serious negative consequences. But they also have to be well ventilated for infectious reasons, for reasons of pollution, a variety of other reasons. That potentially provides a tension if we're also at the same time trying to reduce carbon emissions. I'll come back to this one. Healthcare uses very large numbers of disposables. Very visible, I think, during COVID, but it's true as part of routine service. Again, huge carbon footprints if you aggregate them globally. Taking the NHS, it's a major contribution. The NHS transport fleet is one of the largest in the country. What it does with its carbon emissions has a big impact on transport more generally. And there are specialist areas, for example, some anaesthetic drugs are quite significant potential greenhouse gases in their own right. And there are alternatives, which are less bad. None of them are going to be absolutely perfect. The same will be true, for example, for inhalers. So we have to look at this very seriously as an industry, as a set of professions. Then the bit which is on the face of it, the easiest, promoting benefits, promoting policies with co-benefits. There are some very clear win-wins in this area, and we should celebrate them without trying to pretend that's all the areas. The most obvious, I would say, is promoting active travel. Walking and cycling has multiple wins. You can't go wrong, essentially, in terms of health. It's brilliant for almost every area of health if you improve people's activity levels. And at the same time, it's going to take people out of cars, out of other carbon-intensive areas. So that's an easy one. And we've come from a place, this is just, I put this up because there's often assumption is really difficult to do. If you went back to the 1940s, there was huge amounts of cycling. So we're just going back to something which was completely normal for our grandparents' generation, cycling and walking. Loft insulation would be another one. Good, very good thing for elderly people, reduces their bills, second co-benefit, reduces carbon, third co-benefit. It's kind of every time a coconut. Then we come on to more nuanced things, including air pollution. And I'm doing a report this year on air pollution, so I'm kind of wading through some of this at the moment. The switch to electric cars will lead to a reduction in tailpipe emissions, good for air pollution. There will be some other particular matters. NOxes essentially go out of the window completely, and it's good, by and large, for carbon. So that's a kind of co-benefit, pretty clearly. It's not a complete answer, but it takes us some of the way. As the steady move through the Euro standards, as cars are made more and more efficient, one of the ways that they've reduced their emissions is to use less and less carbon. That's good for everybody, essentially. So there are co-benefits. But then there are some ones where there are, and then reducing carbon use in industry. Again, large numbers of co-benefits. A lot of this is happening at the moment. But then there are some where there are policy tensions. The switch, for example, from petrol to diesel, which was a deliberate policy decision of the government, may have been good at the margins for carbon, but was bad for air pollution. And the two were not really brought together as a single policy. And the use of renewable wood for space heating, some of it in homes, largely middle-class homes, I have to say, and some of it in industry, may be good from a carbon point of view, but potentially is going to produce actually a significant increase in particulate matter air pollution. That is a trade-off. We should be honest about it. The third thing that I talked about was science and engineering to reduce but not eliminate health impacts. And here, science is infinitely powerful. So I've talked about the fact we will see an increase in the range of some major vectors. Let's take, for example, Aedes mosquitoes, which are vectors of several major diseases, dengue, Zika, chikungunya, yellow fever, for example. Aedes albopictus, one of the Aedes vectors, is steadily moving up north through Europe. Almost certainly climate change is contributing to that move. And there is a realistic possibility with continuing climate change it will start becoming established here in the UK. So we've got a vector, but we in scientific terms will probably not be able to get rid of the vector, or at least not easily, once properly established, but we can get rid of the diseases. We already have highly effective vaccines against yellow fever. I think we will get moderate and then good vaccines probably against dengue, Zika and chikungunya. So we can mitigate the effects of this. Essentially, this is a form of adaptation. We can have medical countermeasures to several diseases. We can actually produce engineering solutions to reduce the health impact, for example, of heat stress, for example, of flooding. And taking agriculture, we can produce drought and flood-resistant crops. These are all within the ability of science to do it. It is not a complete solution, but at least if we identify the problems, we can produce solutions to them that help, to some degree, to reduce the impact. And the final general point I wanted to make was about being honest with ourselves and identifying policy tensions. The worst way to make policy in government, I say with deep feeling, is to think that the thing you want to achieve does not come at a cost when it does. It is absolutely essential that at the beginning you're aware of the cost that's involved and are honest about it with yourself, with those you're advising and with the general public, and then try and find a way to reduce the tension. And very often there is a way to reduce the tension, but imagining it's not there leads to, in my view, poor policy outcomes. So an example of this, which I talked about earlier, is that the tension between the clear need to increase ventilation in the UK, both to reduce infection, COVID being the most recent, also flu, and the clear need, and indoor pollution in many areas, and the clear need to reduce the excess use of energy to keep temperatures high or in summer low. Those are in tension. The way we generally in winter keep our ventilation good is to open windows and pump up the heating. Well, that works, but you've then got a policy response which improves one thing. And if you go the other way, you end up with a reverse effect. And what I've seen in the last year, whilst we're talking about ventilation, is large numbers of people arguing passionately in one area of science for increasing ventilation and opening windows everywhere. In another area of science, some equally distinguished scientists arguing passionately for sealing windows and keeping things warm, things properly, most effective way of reducing excess loss of heat. And those two have not talked to one another. And we have to bring them together. And there are ways that this problem cannot be resolved, but it can be to a large extent reduced. And I've just given some example, for example, of cross-plate heat exchanger as just one way of considering this. So my summary, and this is really a framework, is we need to get healthcare as close to net zero as we can. We need to promote the policies that have co-benefits, and there's a sliding scale of those from ones where it's a clear co-benefit to ones where it's a bit more complicated. We need to find countermeasures for diseases that will occur as a result of global warming. It is not a matter of if, it's a matter of when. And above all, we must be honest about trade-offs and then seek, as scientists, to minimise them. Thank you very much.
Thank you very much, Chris, for that excellent introduction to lay out the context of this discussion. It's a pleasure to welcome our third speaker, but it's not your turn yet, but I'm glad you arrived and got here safely. Our next speaker is Professor Mike Tipton, who is Professor of Human and Applied Physiology at the University of Portsmouth and is a trustee of the Physiological Society. His research is in the areas of drowning, thermoregulation, environmental and occupational physiology, and survival in the sea. He's a member of the Council of the RNLI in that respect, and has been a consultant in survival and thermal medicine to the Royal Air Force, UK Sport, and the English Institute of Sport. He's a Fellow of the Royal Society of Medicine and the Physiological Society, and was awarded the MBE for services to physiological research in extreme environments. So it's a pleasure to welcome you, Mike, and if you'd like to take the stage, we'd love to hear what you have to say.
Well, that one's me. Thank you very much for that introduction, and good evening, ladies and gentlemen. It's a great pleasure to be here. I'd like to thank the organisers, and I'm going to come from a slightly different angle. I'm going to talk about the role that physiologists have to play in both the mitigation and adaptation to climate change. As you've heard, I'm from the Physiological Society in the Extreme Environments Laboratory at the University of Portsmouth, which is becoming much more of an everyday event, the extreme environments bit. And just to support that, there's hardly a day goes by now where you won't see a headline of some record-breaking amount of bushfire, flooding, or temperature. And I suspect we're moving towards that for the UK next week. And it's going to get worse, as Chris has mentioned. And I still find it quite amazing that when people read this, it doesn't evoke an enormous response. It just almost is largely accepted by the general public or ignored, and others. And I think there's probably a rate effect in that, in terms of it's still seen as something that's going to happen in the future, as opposed to more immediate problems in terms of things like the energy crisis. But it's going to impact on, definitely on biology, as you've heard, both animal, vegetable and human in particular. But it's also, that's not going to be the only cost. There's going to be a cost in terms of tidying up after these events. And, you know, it's easy to come up with big numbers, but it's probably worth mentioning that it's about £1.5 billion worth of damage for each of the 10 extreme events that occurred in 2021. And the cost in terms of health costs for malaria, diarrhea, malnutrition and heat going forward is estimated to be between £2 to £4 billion per year by 2030. Okay, so that kind of supports what Chris was saying. What can we do about it? Well, the Physiological Society is active in this area, as I think I'd like to see all learned societies be. We have a climate change hub, which I encourage you to go and see. We released fairly recently the Physiological and Climate Change report, which I'll come back to in a moment. We've been working alongside the Wellcome Trust to try and focus some of their calls for work in the area of climate change, which are ongoing. There's this evening's event, and then there's a World Health Summit session in October in 2022, later this year. If we go to look at some of the content of that report, if somebody wants to download it, it's freely available. Heat exposure for workforces and other under-researched groups. We're going to be asking people to work in more extreme conditions. That relates to a decrease in productivity. We've been doing work, for example, in the thermoregulatory responses of flood rescuers. The 1 in 100-year flood is now coming every 2 or 3 years. And we're finding predictions of people getting to heat stroke in about 45 minutes trying to do flood rescues that, in the warm conditions in which they can occur. Deteriorating air quality. There's a 54% increase in deaths associated with heat exposure with high ozone levels. Flood and drowning risk. When the air temperature gets over about 30 degrees Celsius, there's a close to 70% increase in the number of drownings. Completely counterintuitive, but it's because people choose to leap into cold water to cool off. And particularly at this time of year, the water's still plenty cold enough to induce all the physiological responses that result in drowning. Food safety, we've mentioned, animal conservation, biodiversity, mental health and well-being. So they're all touched on in that report. And then for tonight's event, there is a report which I'm sure you've got your hands on, which is there, which goes through some of the areas. Now, when I came this evening, I had 10 minutes. I've now got 15, which is why I'm going to give you a few anecdotes and speak more slowly than I normally do. But no, let's go and have a little drill down into something. So here are the challenges that you've heard about: increased average temperatures, extreme weather events, pollution and disease. And on the response side of this particular slide are all the different areas where physiology and physiologists are getting involved in order to try and improve the situation. With the priority on mitigation, we have to do that as opposed to adaptation. Acclimatisation, for example. In high-income countries, we have lost our thermal resilience. We spent 90% of our lives living indoors, and we use about 30% of our primary energy sources to keep that indoor environment comfortable in terms of ventilating it, heating it, air conditioning it. I've been asked quite a lot of times this week in the media, why is it that other countries, middle and low-income countries, have people that can do much better in the kind of conditions that we're experiencing now? And the answer is twofold. Firstly, it's firstly, it's behavioural adaptation. People know what to do when they change their lifestyle. And secondly, they are much more thermally resilient. We've become thermostatic. We don't experience and we don't get to tolerate or acclimatise to changes in the thermal environment. And that's causing problems. So just going one level lower, and I've chosen, unsurprisingly, heat waves to talk a little bit more about. You can go through all of the problems associated with being exposed to the heat. They're on the heat-related problem column on the left here: increased cardiovascular strain, clot formation, particularly vulnerable populations of the elderly. Once air temperature gets above about 26 degrees Celsius, we start to see an incline in the number of heat-related deaths. Heat waves producing around about 700 or 800 deaths in mostly the elderly, over 65, over 70 age group, children also being vulnerable because they heat up quickly. So we know the mechanisms of that particular and those particular problems, a combination of cardiovascular stress compounded by dehydration, and in heat stroke situations, multi-organ failure caused by, amongst other things, a leaky gut and multi-organ failure, as I say. And we know the neurophysiological and function and vascular physiology associated with these problems. More information is required. We know relatively little, for example, about chronic exposure to specific populations, such as children, elderly, pregnant women, the disabled, and people with comorbidities. So we still have lots to learn in order to give appropriate advice. I've circled manipulate the thermal environment because it leads on from what I was just saying, and it gives you some idea of the winds that you can get. We understand what makes you feel the way you feel about a thermal environment. We know the afferents, we know the peripheral receptor functions. Nobel Prizes have been awarded for these things. And we know how that's integrated, and we know how that evokes thermoregulatory responses, and we know how it evokes your sensations of thermal comfort and heat and cold. And we also know how they relate to the environment you're in terms of the radiant heat load, air movement, absolute temperature, humidity. And it is possible to manipulate those in a way where you minimize energy costs and still retain comfort. So the mitigation aspect of understanding how the body works, which is physiology, of course, is a reduced dependence on energy-consuming technology and improved thermal comfort, or at least maintained thermal comfort, in warm and cold environments. So this is some work from Professor Jay's lab in Sydney, and obviously Australia have been going through all kinds of almost biblical experiences with flooding and fires. And we know that if you increase the air velocity across the skin, you also increase the thermal comfort threshold by about 3 or 4 degrees, depending on how fast the air goes across the surface of the skin. Now, by increasing that, you're deferring when somebody will go and switch on an air conditioning unit. And so you can see with no fan, the greenhouse gas emissions due to the use of air conditioning is around about 5,000 kilotons. Once you get air moving across the surface of the skin or the surface of the body, you're now offsetting, increasing that thermal comfort threshold to the point where you're using the air conditioning less, and now you're down at around about 1,000 greenhouse gas emissions in terms of compensation. Here's some work from Hui Zhang out in Berkeley. This is looking at the set point temperatures in different US states and US cities. And just look at the set points there. I don't know if this pointer will work. Let's have a look. The set point here, around about the set. If you just change the set point of the thermostat from 24 to 25 degrees Celsius, you've got a 7 to 15% saving in energy use. With heating going from 21.5 to 20.5, so reducing the amount of heating, a 3 to 13%. Just changing the airflow from 30% minimum airflow to 20%, 17% or 27% going 10%. There are things you can do that will have a significant knock-on impact in terms of energy consumption and greenhouse gas emissions. All based on, of course, an understanding of how the body works, physiology. And the same information can be used then in helping in the design of the urban environment. What's going to be acceptable to individuals? What's going to make them retain their levels of comfort and their ability to accept an environment? And that's going to involve working and collaboration with a whole range of individuals. And it may well be we need to have botanists, physiologists, medics, architects, a whole range of different skills coming together to create cooler urban spaces. One of the problems and one of the reasons why, of course, you see more deaths during heat waves in urban environments is because they don't cool down overnight. That island effect, that thermal heat island effect, which means they stay high, so people have deteriorating sleep, and that has knock-on effects for their health. We've heard from Chris about making sure that we have things like active travel and also sustainable eating. And I'll just mention that because we'll go then away from just temperature regulation. We know food production is 20 to 30% of UK's greenhouse gas emissions. 60% of dietary-induced carbon footprint is from meat. And obviously, around the globe, there are large swathes of forests being destroyed in order to create grazing. What physiologists and nutritionists are doing working in this area, trying to get plant-based, protein-rich foods that are more sustainable. But you have to make sure that those plant-based substitutes provide the same essential acids, amino acids and leucine, etc., that will help people maintain their health. So developing sustainable proteins that meet nutritional requirements to reduce methane emissions. Another area of understanding, again, how the body works. So the policy priorities is using our understanding of physiology and the consequence of that disturbance to physiology in different aspects of climate change is the first step in attempting to mitigate and adapt to climate change, with the emphasis being on mitigation. As with many other societal challenges, understanding how the body works and goes wrong is critical for optimising the response to climate change. A multidisciplinary approach and suitable funding models that allow you get money to put a botanist with an architect, with a physiologist, with a medic, will be required to address the health challenges of climate change going forward. And policymakers in the UK should be making decisions to keep people in the UK safe, that's immediate policy action, as well as supporting countries elsewhere through research and funding. I'm delighted to learn that the Wellcome Trust are doing exactly that by funding PIs in other countries, middle and low-income countries. And in terms of immediate policy action, the Physiological Society called this week for us to name and rank heat waves. We do that with storms, and heat waves kill a lot more people. And there's plenty of evidence from the LSE, Oxford, various other universities around the globe, that actually naming and ranking a heat wave improves focus, improves coordination in terms of the response to the heat wave, is very good in terms of public awareness and public understanding, and promotes behavioural modification. And the one thing that's going to make the difference in the short term, before we get to altering the way we design places and the way we design the urban environment, is to get people to change the way they behave. They may have to become more Mediterranean. They may have to have a siesta. Who knows? Thank you very much. Okay. Thank you.
Thank you very much, Mike, and a lot of very things pertinent to our current situation there. Well, our final speaker is Dr. Modim Watsama, and it's a pleasure to welcome her here. She's Head of Interventions for Climate and Health at the Wellcome Trust, where she is leading the Trust programme on research to support science-based solutions for climate change and health. She joined the Trust in 2018 as Senior Science Lead for Food Systems in the Our Planet, Our Health programme. Prior to the Wellcome, Modi was Director of Policy and Global Health in the UK Health Forum. Her work focused on research, advocacy and policy development for the prevention of non-communicable diseases, the main health co-benefits of climate change mitigation actions. Modi is a registered nutritionist and has earned a doctorate in public health from the London School of Hygiene and Tropical Medicine. So, Modi, the floor is yours.
Hopefully that goes in there nice and easily. Just pull that out for a second. Escape.
Presentation. Watsama. Yes, thank you.
Fingers crossed. Why is that not coming up? Any idea why that's not?
Good evening, everyone. Thank you so much for bearing with me.
There you go.
Thank you. Yes,
Yes. There.
thank you. So I'm going to give you an overview of our climate and health strategy at the Wellcome Trust. In 2021, September, the Trust embarked on a new strategy and approach to investing in science to solve the world's health challenges. We still continue to fund discovery research, but a new way of investing is focusing on solving 3 of the world's global challenges: infectious diseases, climate and health, and mental health. Our discovery and challenge areas programs are underpinned by a big focus on diversity and inclusion, as well as promoting positive research cultures in the research that we fund. And over the next 10 years, we're committed to spend £16 billion in this strategy globally. So I'm going to give you an overview of what we're planning to do in climate change. This slide from the Global Climate Action Tracker basically summarises the different types of pledges and commitments that have been made towards the Paris goals, policies and action in the real world, the commitments that have been made towards the 2030 targets for the NDCs, pledges and targets towards the 2050 targets, and then a really optimistic scenario, which includes all announced targets, including net zero targets in different countries. And what it shows that under all scenarios, global commitments to date and policies in action are not enough to meet the Paris goals. So we're on a trajectory to continue with global warming and increasing climate change. So within Wellcome, our mission is to accelerate action and progress towards mitigating against this climate change by putting health at the heart of climate action, and also investing in solutions to help protect people from the global warming that is already baked into the system. Even if we do meet the Paris goals, the world is going to be at least 1.5 degrees warmer regardless. So we're going to generate evidence to spur action, inform actions to mitigate and adapt, and advocate for coordination and cooperation to help build a healthy and sustainable future. So our strategy has 4 goals in climate change. The first is transformational advance in the availability, access and use of evidence on the direct impacts and effects that climate change is going to have on people's health in different regions of the world. So we want to fund research to better understand the mechanisms by which things like increasing floods, fires and droughts are going to adversely affect people's health. But we also want to quantify those impacts, both in terms of health costs and economic costs globally. Then the second goal is really to support a transformational advance in the generation and use of evidence to identify what are the effective mitigation actions that can help us meet the Paris goals, or perhaps even exceed them, but then also at the same time promote health co-benefits in the way that we've heard Chris and Mike are highlighting. The third goal is really an transformational advance, again, in the generation and use of evidence to identify what are the effective adaptation solutions to help protect people, particularly vulnerable groups and communities, from the adverse effects of health. And then we have a fourth goal, which is really around catalysing the development of a global community of policymakers, members of the general public, and communities who are able to use the evidence that is generated and understand it in order to drive health-centred action. So this is a broad field-building goal. It includes a goal to really ensure that the evidence generation and research and evidence generation process is developed in standardised ways. So researchers from different disciplines are better able to collaborate together through improved methods, data platforms that can integrate sources of data from different sectors, as well as things like other tools that can facilitate the research process. And I'll give some examples on that later in this presentation. We have another part of this kind of field-building objective is really around targeted capability building for diverse fields of researchers, policymakers and practitioners who are both able to understand what do we mean by transdisciplinary research, so bringing together researchers from different disciplines and policymakers, practitioners, implementers from different sectors to co-create the evidence, identify the priorities together and invest in the solutions. And then we have a learning goal, which is really around developing a set of metrics to help us measure progress towards achieving the field, whether it's through the numbers of researchers trained, the numbers of policies that integrate both health and climate objectives within them, or general awareness amongst the public and populations around the need for climate and health action. So some examples to bring this strategy to light of early investments that we are making or have already made. On heat adaptation, we launched a call earlier this year to evaluate interventions to help protect people from the excess exposure to heat in low and middle income countries, particularly focusing on Africa, Asia and Latin America. That call really promoted transdisciplinary research, and because it was focused on communities who are most at risk and affected by climate change, we required that the principal investigators for these research programs be based in the countries where the research was taking place, and also be nationals of those countries, in order for the policymakers that they were going to be engaging with to basically develop more sustainable relationships with them, strengthen capacity in those regions to be able to undertake that kind of research in future. And also we know that policymakers are more inclined to listen to the evidence when it's coming from their own experts as well. So that's kind of a model of how we're planning to invest in future. This particular call recognised that at the moment capacity to undertake this sort of research is not as strong in developing countries. So we're very much promoting global north, global south partnerships, but really ensure that there's a transfer of skills and expertise during the process. So the countries where the research is taking place are better equipped to undertake the development of solutions for themselves in the future. We've also currently have a call on biological vulnerability to extreme heat in mothers and children, which we developed with colleagues at the Physiological Society, and the other call as well. Also, the meeting that we jointly held earlier this year really helped with that process. And this again is aiming to understand the mechanisms by which chronic exposure to excessive heat in mothers and children actually impacts the biology of mothers and children. And that's a global call, so the researchers can be based anywhere in the world. It's addressing a clearly identified gap, as we heard earlier, in this physiological research space. So it fits with our climate impacts goal that I highlighted before. And then the third call that we're launching this year, which was just launched yesterday, is really a global call focused on G7 countries, which is really aimed at funding transdisciplinary research team to develop evidence which can help advance the adoption or implementation of climate mitigation policies which have health co-benefits. And so those policies are particularly, we're interested in focusing on policies in the food systems, energy, transport and housing sectors. Again, we want the partnerships in this call to be transdisciplinary, bringing together both policymakers and policy implementers or other policy actors and researchers together. So the applications to this call will need to demonstrate that there is a particular policy opportunity that the research project can directly feed into, whether it's an opportunity to adopt a new policy and the advocates are like, this evidence would really help, or perhaps an opportunity to improve the implementation of a particular policy through, for instance, evaluating a policy to see why it's working and how implementation could potentially be improved. We've chosen G7 countries because of their high levels of historic emissions, but then also their influence globally on the global stage, and the fact that they have a moral responsibility to lead the way. So those three calls I've just illustrated show how our strategy is global in scope. We're aiming to focus on mitigation, placing responsibility on those with historic responsibilities to lead the way in mitigating, but then also adapting and focusing on the countries who are going to be most affected by climate change to help them develop solutions that can protect their health. We recognise there's also a need to support emerging and developing countries to develop more sustainably, avoid the pitfalls that we've seen in developed nations. And so we will also be investing in sustainable development pathways which avoid locking in carbon mitigation, high carbon ways of growing their economies and developing. And those will be some of the investments that will be coming in the next year or two. And I'll just end on giving some examples of our investments in field building. The first one is we've invested in a group to help develop national statistics, improving the ability to track the health impacts of climate change through developing the capability of national statistics agencies and convening the international community around reporting methods and standards. This work is being led by the ONS in partnership with the Cochrane Climate and Health Working Group and other partners in a selection of developing countries to really help improve that process of developing climate and health data in standardised ways, so that we can perhaps end up with ways in which we can have international comparisons and better ways of being able to do the research. In the middle is an example of a piece of research that we funded late last year, which is really commissioning the IISD. Apologies, I'm not sure what I can't remember what the acronym stands for, but they're a global environmental advocacy group who target UN processes like the climate COP, the biodiversity COP, chemicals and pollution policy processes. And what they did was they looked at the opportunities to integrate health in the global environment agenda. And so it's basically a toolkit for any public health actors or health actors who are interested in ensuring that other sectors whose policies have an impact on health in the environment space can actually integrate health into their priorities. And because a lot of the climate change solutions that affect health lie outside of the health sector, we need to strengthen the capacity of both health and non-health actors to be better able to identify those linkages and develop policies which deliver win-win solutions for both the environment, climate and health. And then the third area of an investment that we have been making since about 2015 is the Lancet Countdown, which is basically a global project that tracks progress towards the Paris goals by tracking progress across 44 global indicators. So that's one way within which we're helping to track the progress towards the Paris goals and how that progress is impacting health impacts. Other things we're planning in the field building space is thinking about how we might develop communities of practice in developing countries, Africa, Asia and Latin America, which bring together researchers with policymakers to identify what the research gaps and priorities are for those regions and co-develop strong proposals to our Wellcome funding calls, which kind of meet the transdisciplinary research objectives and priorities that we have. And we're also exploring how we might develop fellowships, both for policymakers and training opportunities, both for policymakers and researchers, to be better and able to undertake the sort of research that we would like to promote and actually help us all meet our objectives to put health at the heart of climate action. That's a bit of an overview of our new strategy in Wellcome. We're very much open to ideas on whatever people see as the gaps and opportunities, both in the UK, this is where we're based, so this is one of the priority countries we're going to be investing in going forward, but then also globally. So looking forward to hearing everyone's thoughts. Thank you very much.
Please stay up there now.
Great.
Should I welcome Chris and Mike onto the stage? So we've now come to the Q&A session, of course. Just a reminder, we're going to take questions directly in the room or on Slido for our online audience, but you can use Slido if you wish in the audience. Use Slido with the reference number I'll give you again, hashtag 1789886. And as well as asking the questions, you can upvote other questions. That's a new word to me, but it sounds rather rude, actually. But anyway, and we can see which questions are getting the most votes. And please give your name and affiliation, and I'll get this working here. So could we invite the first question, please? And could you give your name and affiliation, lady here, please?
Is this working? Yeah. Thank you very much. Anna Dominczak, Researcher of Medicine, University of Glasgow, and Chief Scientist Health for Scotland. I would like to ask all three speakers, maybe starting from Professor Sir Chris Whitty, what are one or two important things that NHS across the UK is not doing yet and should be doing to mitigate what you've shown us and what we know is happening around us?
Thank you, Anna. Who would like to take that? Chris? Or?
Thanks, Anna. And I think there's sort of some quick things that absolutely have to be done now. For example, I think we need to look very seriously at the transport fleet because we know what to do and it's just a matter of accelerating it. All of these things, of course, come with a cost, and that, you know, I don't speak for NHS, and they're obviously having to trade off, again, different risks, but that's one of the quickest ones. And then there are the much longer term ones, and I would probably put this issue about how do you maintain very good ventilation for infection control and good heating and cooling for maintaining the right physiological temperature for vulnerable people, which our intention to get that to the point where we actually can maximise get to the sort of the best point on the ROC curve between those two aims, if I can put it that way. There are lots of things in between that, and if I was going to take a third, I'd probably go for disposable waste, which I think we are extremely haphazard about at the moment, and has a very significant carbon footprint.
Mike, do you want to comment?
Nothing to add to that in terms of the NHS. I think generally quite a lot of it's about behaviour change. And I often think, I go to so many meetings now, I often think that if I could take 2 people to every meeting, it would be a language expert and a behavioural psychologist. Because a lot of what we do, and I mean I suspect Chris experienced this through the pandemic, you know what you want people to do, the problem is getting them to do it. And how you go about getting people to do it. And it'll be the same next week. We know exactly. I can tell you now 10 things that will save your life next week. But whether you'll get people to do it, whether they'll still be out and turning up at A&E because they're sunburned, is another question.
Gentleman there in the cream jacket, please, with his hand up.
I was going to... Sorry? Thank you for the talk. Sorry, it's come on now. I just want... It's Rick Fordham from the University of East Anglia Medical School. I just wanted to ask Chris and indirectly probably Mike...
Sorry, could you speak up a bit?
Yeah, I'd just like to ask Chris and indirectly Mike as well. Chris made the point about increasing people, getting people to increasingly take up cycling, which is obviously very beneficial for reducing carbon, getting people out of cars. But we've also got to bear in mind we're getting a hotter and hotter climate. How do you expect more people to be cycling around in a hot climate? I spent quite a lot of time in Australia. I know Perth, Western Australia, very well, and it has fantastic cycling infrastructure, but it's got very hot temperatures in the summer, obviously, and it is the highest utilizer of cars anywhere in the world, I think. You just can't get people out of cars driving around for very, very short distances, and yet, we could be asking them to cycle, but they simply won't because it's too hot. So how do you overcome that dilemma?
Chris and then Mike.
Well, I think in the UK we exaggerate how cold and how hot it is at all times. Compared to many of the places that I've worked. I mean, most places in Africa and Asia I've worked are much hotter and a lot higher proportion of the population cycle, if I'm honest. So I think there are going to be a few days of the year already, and there will be more in due course where it may be tricky, and particularly tricky for people who have whose physiology is less able to adapt. The great majority of people can be sensible on these things, and for most of the year in the UK, I don't think that's going to be a major barrier.
Mike?
Yes, I mean the challenge is going to be to get people to do anything. We just wrote a paper entitled, which basically summarises the evolution of humans from ape to apathetic. I mean, as an employer, you could say, well, if you come into work earlier and go home later, it'll be cooler. It won't go down well. But you can, I mean, one of the ways you adapt to a warm environment is you change your lifestyle. And we've been talking quite a lot this week about a Mediterranean lifestyle where you do your physical activity at times of the day when it's cool enough to do it. And because there's absolutely no doubt that if you look at the burden on the health service of a sedentary lifestyle, it's enormous. And so if it means that, get up early, go for a bike ride, go out late, do some swimming, do something else, but for goodness sake, do something.
Take the... Yes, with the microphone, then I'll do a couple of online questions, and then there are a couple of at the front who would like a microphone. Gavin, please. Yes, please.
Yes, Judith Petts, Vice-Chancellor of the University of Plymouth. A question around mental health, which was actually on Mike and Modi's slides briefly. But what do we know about the mental health effects, firstly, of, say, warnings as we get more and more extensive warnings, thanks to the Met Office, with names and big red lines and big amber patches and things. What do we know about the effects on stress on people of that? And what do we know about mental health effects of major events in terms of storms, flooding, where you have direct harm, of course, but also you have long recovery periods afterwards? And if we know quite a lot about mental health effects, what are the policy implications?
Yeah, a good question. Who wants to take that one?
Well, that's probably going to take us right the way up to dinner. There, from one perspective, yeah, the group that often suffer the worst with these things are the rescue services, and we do lots of work with flood rescue, for example, and the Fire and Rescue Service, RLI. They have good systems in place to deal with the kind of mental, long-term mental problems that you can get from those experiences. From Plymouth, you'll notice that there's lots of people throwing themselves and going swimming in water, and they make all kinds of claims for the benefits to their mental health. So I'm not saying that a heat wave and being uncomfortably hot is necessarily good for you, but we do need some aberration. We're a homeostatic animal, but that homeostasis needs to be perturbed, and that the problem is, as I alluded to when I was talking, is that we just don't do that anymore. I use the example of the musculoskeletal system. It's there, but if you don't use it, it'll atrophy. So I don't think, I think actually that it's not a bad thing for mental health to become a little bit more resilient and a little bit more exposed to some extreme conditions. The other side of that coin, of course, if you find that for weeks on end you're kept indoors because you can't go out in the middle of the day for 2 or 3 hours because it's so hot, then that in itself is a problem. I think we saw some of that through lockdown, didn't we?
Modi, you have a view?
Yeah, just to add to that, this is, hopefully one of the things we'll be doing supporting a bit of research in, but certainly there's evidence from places like India, things like early warning systems during heat waves actually have been associated with reduced deaths from those heat waves as people respond and take measures to protect themselves. So naming hazards can have a positive effect, and actually warning people about the effects. And then the other thing, there's actually strong evidence to show that if you fail to protect people from things like floods and fires, and they end up losing, for instance, livestock, crops, that's livelihoods, there really is a negative mental health effects associated with those hazards, things like increased suicides amongst farmers. So, there's adverse mental health effects if you fail to actually adequately warn people and help them take measures to protect themselves or introduce the policies. But we certainly also do need to, so that's an argument to say that the things like naming heat waves or whatever they might be have positive benefits. Obviously, we need to look at the positives and the trade-offs, but certainly from some of the people we've spoken to in the evidence, it suggests that the net benefits of some of those measures can be overall positive.
Chris, do you?
One of the first things you learn in medicine is that everyone will tell you shouldn't give people bad news. And that's absolutely false. You should give people straight news. You should simply say this is what's going to happen. It doesn't alarm people. People are actually remarkably good, provided they think you're being straight with them. What isn't right, of course, is to say things deliberately to scare. That is absolutely wrong. But to say things that this is going to happen, it's just a fact, or this is highly likely to happen, that is actually simply our responsibility as scientists to do that in as unhistrionic a way as possible. In terms of there is a large literature on emergencies and their impact on mental health, and it depends very much on the emergency and on the setting. But I think, again, people often underestimate people's resilience. People are remarkably resilient to things, but they do want to feel in control of their lives, and a lot of that does depend on having full information.
I'll take 2 or 3 online now, just to be fair to those following online. One from Modi here. Is the Wellcome Trust looking at how the delivery of the research itself will impact climate in making the awards?
Yes, absolutely. That's an area of work we're looking into. We've currently got a request for proposals for a team to develop tools to help researchers better quantify the impacts of their research in terms of emissions and other environmental impacts, but then also think about a toolkit of how they could actually think about mitigating that. So that's an area of work that we're currently investing in order to ensure that the research that we fund is as sustainable as possible in the future.
And another one, how can we train medical practitioners to explain climate change to patients and the health benefits of net zero, clean air, green spaces? One maybe for Chris, and then maybe Modi would like to comment.
Well, I think that medical practitioners are one of the groups, but only one, of people who are scientifically trained to the population come into contact with on a regular basis. So I think it is important that medical practitioners feel comfortable and able to explain these issues. But I think it has to be put in context. If someone's come in with a broken foot and then someone chooses that opportunity to talk to them about climate change, it is clearly not going to be a totally productive conversation. So I think you need to do it within the context that is necessary. But I think there are many opportunities for people from medical background to do this. But I think there are many opportunities for many other groups to do this. Probably the greatest opportunity may well come from science teachers who are able to have a much more extended bilateral conversation with people they're talking about. Children and young people are extremely interested in this subject and they want to be furnished with the accurate scientific information. So that's another professional group that people come across and trust and have a proper interaction with.
Modi?
Actually, Chris has said exactly what I would have said.
All right. Mike, I think you have a point.
Yes, I don't think it necessarily has to all fall at the feet of NHS staff and personnel. There are some pretty smart initiatives. So, for example, the British Association for Sustainability in Sport has been trying to preach the climate change message through the impact that climate change will have on the sports that millions of people follow. It's a nice way of doing it because it personalises it to them. So, for example, there's one report written which is called Hit for Six, which is the impact of climate change on cricket. Why cricket? Well, because cricket is the second most watched sport on the planet, and lots of the places where it's watched are under the most threat from climate change. Another report, Rings of Fire, which was focused on the Tokyo Olympics. So the way to get people to listen to something is for it to impact them, and one of the ways it can impact large numbers of people is through the sport they love. So, you know, there are lots of smart ways of doing it, and you know, we don't have to do everything within the NHS.
I'll do another online and then we'll return to the audience. 65% of the NHS's carbon emissions come from the supply chain. I think this is one for Chris. Why is it not, as a near monopoly purchaser, doing more to demand that suppliers decarbonise? And you did mention the NHS fleet, for example, of vehicles being one of the biggest in the UK.
Well, I mean, it clearly has to, and I think it has accepted that. And I think there are now people who are doing this as a full-time role in the NHS, trying to make sure this is taken seriously. I think if we're going to do it, we have to accept that there will be times when there's a trade-off against price, at least initially, whilst the transition is made, and we should be straightforward about that. But this is an absolutely essential activity for the NHS, as of course for every other activity, but in this particular context, the NHS.
Could we come back to the floor and the gentleman in the front row there, and then in the row behind, and then the lady with her hand up, I think.
And thank you, Andrew Mackenzie from the Physiological Society. We've seen, whether it's the war in Ukraine or the cost of living crisis, climate change fall off the agenda. How do we make sure that when there is a short-term urgent problem, of which there will always be another short-term urgent problem, that the long-term issue of climate change is maintained as a political and public priority?
Yeah, good question. Do you want to have a go, Molly?
Yeah, I mean, I think that's a really good question. And so in response to the immediate war in Ukraine, that's actually turned also into an energy crisis in countries that are dependent on Russia to import gas, for example. And so there's an opportunity to reframe that as, if we were to invest in renewables, then we wouldn't necessarily have to rely on importing gas, and that would make our energy supply both more sustainable environmentally, but then also politically as well. So I think it's being, as advocates, we need to be agile to be able to spot the opportunities to frame the current issue of the day as one that relates to climate change. I think that's, kind of one example where you might be able to do that.
Anybody want to?
It's a good question, Andrew, and I even knew you were going to ask it, and I haven't got an answer. But I think you probably can't do it by trying to necessarily to convince policymakers. What you need to do is convince the general population. You've got to personalise it. I mean, when I look at that slide of what's going to happen in 30 years, and I've just had a grandson born, that drives me. It's happening. It's happening. There is definitely a greater interest in climate change and the impact of climate change. But unfortunately, sometimes these things take a generation, and we don't have a generation. So I don't know, but I think you've got to target people and personalise it, and that's what's worked in other campaigns where you're looking for change.
Gentleman in the second row, please.
Hello, I'm Richard Smith, and I'm the chair of the UK Health Alliance on Climate Change. And I wanted to build my question around two words that you didn't mention. One is justice, and the other is biodiversity. Actually, Modi did mention biodiversity. She talked about the biodiversity curve. If you talk to young people, they see this whole thing in terms of justice. The people who strike on Fridays are all holding up banners talking about justice. And we had a webinar recently run by a medical student at Cambridge, and she expressed it entirely in terms of justice. Because, of course, it's the high-income countries, and particularly the rich people in the high-income countries, mostly people in this room, who created the problem, but it's people in poorer countries who are going to suffer the most. And then within this country is the poorer people who are going to suffer the most, not the rich. The rich may well use air conditioning, which will make the whole problem worse. So whether on how successful we are, and we're being very unsuccessful at the moment, we need to reduce global emissions by 7% a year. They're actually going up by 7% a year. We will have to make huge payments towards low and middle income countries to support them in what they're doing. So what is the chance of that happening? And then to talk about biodiversity, I mean, we're called the UK Health Alliance on Climate Change, but actually biodiversity is just as important. These are twin problems, and yet we are not paying anything like the same attention to biodiversity as we are to climate change. So how can we address that? There's two easy questions for you.
Right, thank you. Well, Modi, you mentioned biodiversity, and then Chris will deal with the policy issue.
I did indeed. On the biodiversity question, so the lens through which we're looking at these global challenges within Wellcome is through climate change, but biodiversity does, come into the equation. For instance, nature-based solutions for things like planting trees can help both prevent climate change through absorbing carbon dioxide from the atmosphere, but then also can provide shade. There's a question earlier about cycling. Can also provide shade and help protect people against rising temperatures. It's always nicer to be in the shade if you're in a hot place, for example. So often these challenges have got linked solutions, and the problems behind them are also linked. Things like deforestation can contribute to climate change. So they're not necessarily distinct problems; they're interlinked. On the question of justice, absolutely agree. Justice is really critical. I started by saying our strategy is also underpinned by equity principles within that. So we want to support the generation of evidence to show the inequitable distribution of both the impacts of climate change, but then also the people responsible for causing it, and ensure that that evidence can be put into the hands of advocates to make the case for action. I'm not sure if I mentioned it before, but one of the key pillars of our new strategy is that we also have a fairly large policy team, as well as a public affairs, public engagement team, and we will, in addition to funding the science, also be investing in different NGOs, advocacy groups to help advocate for the changes that are needed. And the groups that we'll be investing in, I'm sure, will be wanting to promote equity and justice at the heart of it. I started by talking about, when I mentioned our mitigation call that is focused on G7 countries, I mentioned the fact that they have a moral responsibility to lead the way in decarbonising. So justice and equity underpin everything that we do, even if we might not always say it in that way, but certainly that's an underpinning principle of our strategy and the way we want to solve the problems through the investments we'll be making.
Chris, do you want to say anything
No, I
about
think
justice?
Modi did a very good.
Yeah, okay. The lady in the white shirt and the brown.
Is it on? Okay. Good evening, and thank you to all of you for some really interesting presentations. My name is Amy Booth. I am a medical doctor from South Africa, so I really appreciate the conversations about collaborating with the Global North and Global South and how we can learn from each other. I'm currently doing my PhD at Oxford, looking at how we can reduce the emissions across the NHS's supply chain. So hopefully we'll, 3 or 4 years' time, have some answers for that. But I guess my specific question, comment, both Professor Sir Chris Whitty and Professor Tipton, I mean, you both started your presentations with this idea that climate change is the biggest global health threat of the 21st century. That was published in The Lancet in 2009. They recently published a follow-up piece saying that and the inaction of world leaders is the biggest global threat to healthcare of the 21st century. The NHS has been carbon footprinting its healthcare since 2008. So, there's been a lot of delays in this process, and it's to be commended for, reaching out and becoming the first health system to pledge to net zero. But there's still a lot of questions and a lot of challenges that we're going to have to overcome, a lot of unanswered, challenges. Supply chain is one of them. In your pathway to net zero, it mentions innovation, offsetting, low carbon models of care. There's a lot of questions about how those are going to be rolled out. There's a lot of lack of awareness of staff. There's a lack of awareness in the public and patients. So I guess my question is, how optimistic are you that the NHS will be able to reach its targets, and how do we stop the world leaders from just continuously pushing these targets back?
I think that's one for you, Chris, is it?
I'm optimistic the NHS is intending to try, and I'm optimistic that research of the kind that you're doing will help it to get there faster. At a certain point, people are going to have to face some fairly tough choices. So I think we'll do the relatively straightforward things first, and that is perfectly reasonable. But there are going to be some harder things to do as things goes by, and we still have to do them. And that, I think, is where the conversation will get harder, because there will be trade-offs. And this is back to my point about policy. Pretending there will not be trade-offs is disingenuous and wrong. We have to be clear that if we do this, we will not be able to do that, and that is the choice. And that is something which I think we need to be, in a sense, getting people ready to. In terms of how can we prevent world leaders pushing things back, I don't think really as a sort of civil servant, it's my job to do that. My job is to present the science and say, look, this is actually going to be very serious, and there are a bunch of things you can do technically. Fundamentally, that's a political question. And I completely agree with something that Mike said earlier, which is the key to answering political questions is the general public. Political leaders in this area will follow if they feel that that's where the public is, and they will not follow if they feel that's not where the public is. So that really is the place where people need to have the debate, is in the general domain. So it's things like the things we've already talked about with teaching and so on, one generation, but things like David Attenborough doing programmes, various other things like that are really the key, in my view, to getting people the sense of urgency that all of us in this room feel. But that is not where the average person is at this point in time.
Gentleman in the striped tie, and I think we'll be close to rounding up.
Jim Lynch at University of Surrey. I'd like to just encapsulate a couple of the points that have been made. During my stints, 4 years as Chief Executive of the Forestry Commission Research Agency, one of the groups that I interacted with mostly at that time were the Chief Medical Officers in each of the countries, because one of the opportunities for forestry and planting trees is not simply climate change, but it is to provide potential exercise for people to use the countryside. But also, we had quite a lot of European funding at that time to look at the beneficial effects of the forest atmosphere on healthcare. And particularly some hospitals in Germany moved their hospitals out from cities into the countryside to get the benefits of the terpenes in the forest atmosphere. The point I'm making is that we've made a policy decision to increase tree planting in this country, but we're not remotely reaching it at the moment. DEFRA made this as a policy. It's got all sorts of advantages. It's not simply climate change. It has got these other health benefits as well, potentially.
Mike?
Just to agree with what you're saying, I mean, I think the green and blue therapy argument is well established. I see it more from people doing open water swimming and trying to titrate exactly what about that is good. You know, you sometimes wonder, don't you? Anybody who, I suspect a few of you in this room have been to Rome, and if you've been to Rome and it gets really hot, the emperors went to Tivoli. And what was Tivoli like? Pretty much the way we're talking about designing urban environments now, a combination of trees and water. So sometimes, you know, if you ignore history, etc., etc. I just have one comment about a lot of this in terms of changing people's minds, and it's probably something to think about over dinner, and we can discuss it after dinner. But if my good friend and colleague Hugh Montgomery was here, he'd say it's too late. You know, it's happening, and it's going to happen, and there's not much we can do to stop it. The problem with this argument is it's always on a knife edge. If you say it's not too late, people think they've got more time, and if you say it's too late, they think, well, it's too late. So if somebody can find a way of spinning that argument in a way that motivates people and activates them without depressing them or making them think they've got more time, I'd be really pleased to hear it.
Modi.
Just to say thank you for that question. That's exactly the sort of policy we'd like to generate evidence for in the future by assessing both the health and other benefits to society of a policy such as planting more trees. So, yeah, watch this space. That sort of thing is going to be, hopefully we'll be investing in that kind of thing in the future.
Well, our time is up, really. Just one last online question for Chris Whitty. Will you please run for Prime Minister? It's there. I haven't made it up.
No, but thank you for the question.
Well, on that note, yes. Well, you've already clapped, but can we all clap again, though, for all our wonderful speakers and their presentations? And thank you for all who've asked questions online and in the audience. And I'm sorry there wasn't enough time for a lot more questions here, certainly we know. But I hope you'll have a chance maybe to pose them over dinner. You will receive as well, everybody, an email survey following this event, so we'd really appreciate if you could fill that in with some feedback. A recording of this event will appear on the Foundation's website tomorrow. This is the last event for the Foundation of Science and Technology before the summer break. Our next event will be on the 12th of October, when Sir Paul Nurse will be discussing the review he's currently leading on the UK R&D landscape, which should be very interesting. So for those joining us today online, thank you very much, and goodbye to you. For those in the room, there are drinks in the room behind you, and dinner will be served at 8 p.m. So thank you very much, and do enjoy the rest of the evening.